Well, thanks everyone for joining today, and special thanks to Jimmy and the Voxel 51 team for having myself as well as our Chief Technology Officer, Dr. Wu, who's also here to help with any sort of technical questions that are beyond my scope, to answer about some of the work that we've been doing specifically in the veterinary space. And so, as you can see here, I am a clinical medical oncologist in the veterinary space by training. And I think when we think about AI in healthcare, we tend to really focus on human healthcare. But I think there's actually a large gap, obviously being a veterinarian, for the pet healthcare space and the potential opportunities that we have for comparative medicine and translational medicine. So today, this talk might be one of the least technical out of all of them, and that's simply because both Dr. Wu and myself are very passionate about ensuring that we continue to prove and show how model development in the veterinary space can actually translate to humans and helps both species with significant disease. So with that, I'll move on to a little bit of statistics, clinically speaking. Basically in veterinary oncology, the annual rate of cancer diagnosis for pets in the United States is about 4.2 million dogs and 1.6 million cats per year. So that roughly equivalates to about 1 in 4 dogs and 1 in 5 cats that will develop cancer in their lifetime. And that's also about 50% of dogs over the age of 10 years of age will develop cancer as well. And what I want us to remember for a moment, there's a lot of folks that may be aware of in the human healthcare space that there's lots of mouse models and using animals as a precursor prior to human clinical trials. But what's really unique about veterinary oncology is that these are dogs and cats that effectively live in the same environments as us. They eat the same foods, drink the same water, but develop naturally occurring cancers. So they are exposed to a lot of the same things we are. And the dog genome actually, ancestrally anyway, shares a lot more homology with us as humans than other species. And what that means is not only from a clinical setting, when we talk about drug development pipelines, which I'll get into in a moment, is there a lot of overlap. But when we actually just look at the simple biology of tumors and cancer development, and honestly, other diseases in dogs, whether it's neurological, whether it's heart disease, whether it's other forms of infectious and inflammatory diseases, there's actually a tremendous amount of crossover between the veterinary and human healthcare space. And that has really led to the development of comparative oncology. And we'll talk a little bit today about some of the studies performed by the NIH and NIC, but there's an entire subsidiary now at the National Institutes of Health that are completely funded and pushing towards a comparative health platform. And that is explore the disease, explore the treatments in dogs as sort of our pilot, as our canary in the coal mine, and then extrapolate that to the human space. So one of the biggest problems in the human healthcare space, and specifically human oncology space, is indeed the clinical trial pipeline. And that is that drug discovery, which is really your benchtop experiments, start with a multitude of laboratories and even using things like AI to actually try and find compounds that might be validated against a specific target of interest in a specific type of cancer. And across labs, across the country, that can be anywhere from 5 to 10,000 compounds that are evaluated, but that sort of benchmark testing can take anywhere from 3 to 5 years. And without reading every single one of these word for word, what you can start to see is that it can take almost over 10 years before we're hitting the clinical trial pipeline. And then from there, we're taking even more years to finish those clinical trials and move into regulatory approval. And the biggest problem is the high failure rate that we see, which is we went from 5 to 10,000 compounds ultimately to maybe one new drug that enters the clinic. And that drug may only provide a modest or minor improved survival for that patient. And so this is where we feel not only can we insert dogs into that clinical trial pipeline from a medical standpoint, but when we talk about implementing AI in clinical practice, we've also got an opportunity here to utilize veterinary patients and veterinary data for training models that may actually be beneficial to the human space as well, and obviously beneficial to the veterinary patients too. So I always like to frame my talks around a patient story and sort of why we are where we are today. And the one patient I do want to talk about today is Ridley. And Ridley came to me during my medical oncology residency several years ago with a brain tumor. And so what you can see on the right is a MRI image. It's a dorsal view. So his nose is at the top here, where this is sort of a top-down view. His eyes are located here, and this is his brain. And what you can see is this very bright area is indeed consistent with what we would determine as a meningioma based on the MRI features. Meningiomas are tumors of the meninges, and we see this tumor very frequently in humans, both children and adults. And in dogs, we tend to treat these because of their invasive behavior with radiation therapy. And that usually leads to a survival time of anywhere from about 12 to 18 months with radiation therapy alone. Ridley in particular actually survived well over 2.5 years with radiation alone. And, you know, it really starts to get you thinking as a clinician, why do we see these subset of patients when we look at median survivals that actually do much better than we expect? And because our talk is focused around, you know, computer vision today, I think it's really simple to then say, well, can we take features beyond our regular clinical prognostic factors and start to look at image features and other features that can actually start to help predict and help our patients live longer? And again, take that from the veterinary space to the human space as well. And so because of all these questions and because of our collaborators, we've developed sort of our research pipeline and sort of we have multitudes of projects that are sort of ongoing. But because of the talk today, we really wanted to focus on, again, computer vision and radiomics. But the whole idea here being that we have a breadth of species that get similar diseases. And can we take dog data and feed that through a pipeline to develop clinical biomarkers that then we can feed back into the human healthcare space? And that's really our goal at the end of the day. So what's the state of computer vision in veterinary medicine? Since not everybody, you know, here today may even know that there's actually studies in computer vision in veterinary medicine. A lot of the focus, just like in the human healthcare space, has been around radiology. There's really only a handful of studies, to be quite honest. This is really sort of a new development for us as a profession, and really only a handful of researchers that are really publishing active studies at this point in time. But again, kind of highlighting that there's opportunities here for collaboration, and hopefully that you'll take home with yourselves today. But the study on the left was evaluating the ability for AI to identify certain primary chest lesions in dogs. So certain diseases, as you'll see here, like tracheal collapse, heart enlargement, and a multitude of things. But the take home here was that the AI actually performed better than a general practice veterinarian who's not trained in radiology primarily, using the AI as supplement, as well as the veterinarian alone. So how these systems might actually help primary care clinicians that don't always have access to a specialist, at least hone in, like the previous speaker spoke about, hone in on areas of interest. In addition, my colleagues at the University of Guelph have worked on positioning. It may seem quite rudimentary or simple, but simply placing a patient in the right position for their radiograph, and especially us in the veterinary space where we cannot ask our patients to sit still, they must be sedated. The people actually generating the radiographs actually have to position the patient properly for each image. This study actually evaluated the ability for an AI model to actually state whether or not the proper field of view was indeed in place, and with relatively high accuracy and performance metrics. So, you know, from there, that's just in thoracic radiographs, but there's an opportunity again to ensure quality of radiographs are across the board, especially when it comes to a radiologist's interpretation. In addition, following sort of this radiomics thoughts, that's been also applied to MRI images in dogs that have gliomas and meningiomas. And so This is using MRI validation and textural analysis using GoogleNet to actually predict histology based on textural features on MRI. And again, these are relatively small data sets. And I do have to say, in the veterinary space, unfortunately, we are limited by much smaller data sets in comparison to the human space. But this rudimentary evaluation to be able to say that we can actually start to predict histologic criteria or predict a patient with a meningioma versus a glioma is actually very important when we relate it back to the clinical setting. And that comes into play here when we're talking about canines with splenic tumors. One of the most common spleen tumor that we see in dogs is something called hemangiosarcoma. Most often, those patients come through our emergency department with blood in their belly, or what we call a hemoabdomen, and they're quite critical. The problem is that there are benign lesions of the spleen that can also bleed. And so there are patients that unfortunately pass away or are euthanized as a result of a suspected diagnosis of hemangiosarcoma, or blood vessel tumor. And this group in particular here from Italy was interested in saying, could we pre-predict, based on CT features alone, the histology of that patient? And in this study in particular, unfortunately, the model actually performed quite poorly. Now, again, limited data set, and there's possibly some other ways that we could talk about how they could have attributed or could have improved their model development pipeline. But for the sake of today and for sake of speaking clinically, I think again lends itself to this idea that there are actual very big clinical impacts that can be made with the integration of some of these models in our clinical practice in veterinary oncology. It's also been applied to pathology using computer vision for pathomics. And this paper in particular is looking at the active detection of mitotic figures. And for those less clinically inclined, mitotic figures are figures in tumors that are actively dividing. And it's at the state of where they're actually starting to split their DNA. And it's actually very clinically important for me as an oncologist that there are certain types of tumors where that mitotic count needs to be accurate and actually helps me choose to give a patient chemotherapy or not, or predict potential outcome. The problem is it's an extendedly laborious process. There's limited pathologists in veterinary medicine and veterinary oncology, and a lot of cases to pump through. And so this idea was, could we use a computational platform that could actually speed through mitotic count detection with high accuracy and help pathology workflows? And what a lot of people don't know is that they're doing this in the human space now, but it was actually piloted in veterinary patients first. It was a health lab called Antech, which is owned by Mars Veterinary Health, and Mars owns a bunch of big companies, but they were actually the first group to evaluate active and automated mitotic count detection in dogs, and that's being translated to people now. And one of my favorite studies really shows this idea around comparative pathomics and comparative medicine in general, as well as comparative AI. And this is that same group, and they evaluated a data set of canine dog breast cancer. Okay, and they were able to actively count mitotic figures, and they used a pathologist, obviously, as ground truth, fed in their automated system. And then they decided to say, well, hey, if it performs so well in canine patients, can we evaluate how it's going to perform on a group of women with breast cancer? And what you can see highlighted at the bottom is the F1 score was actually really relatively high, and shows that, again, from a rudimentary testing perspective, or sort of playground, veterinary medicine offers a lot of opportunity here to test and develop proprietary models that could eventually be translated to the human space and help patients of both species. And another study, this is actually from the NIH and NIC Comparative Oncology program. We actually see bone cancer in dogs. It's called osteosarcoma at a much higher incidence rate than we see it in children. And what that means is it's actually a perfect platform to be testing and evaluating new methodologies in dogs that then can be translated back to children with such a terrible disease. And so there are a ton of clinical factors that we typically rely on. And this study in particular was looking for a deep learning approach to actually being able to classify very specific histologic subtypes of dogs with osteosarcoma. But all that aside, what they actually ended up finding sort of incidentally was that when they started correlating some of those pathologic features with clinical outcome, they found that the machine learning algorithm was actually able to dichotomize this sort of clustering, which was group 1 and 2 versus 3. And we see this clinically where these patients here, this is a Kaplan-Meier curve for those that aren't aware of that curve, which predicts survival probability over time. And we see clinically this cluster 3 that there is always a subset of patients that seem to be doing tremendously poorly in comparison to the traditional, which is a median survival of about 1 year. And so with that ability of this machine learning algorithm to do this in dogs, they were actually able to go back and apply that to the human space and find the exact same clustering ability, simply because they developed the model in dogs on pathologic samples and applied that back to the human space, which again, I think is really the impact here of comparative computational oncology. So now let's jump into a little bit about what our team here at Animal Health and the Ontario Veterinary College has been working on. We're very passionate about making sure that we utilize technology as well as, and not just tech, but also moving into the AI space to improve the clinical well-being of our patients, but also clinicians' lives. And so our first study is really evaluating iPhone photogrammetry. So using LiDAR detection that's built into the iPhone to demonstrate its ability to take 3D image capture of canine patients with oral tumors. And so you can actually see this is a render from Blender. This is another render here just from the video on iPhone. But we are actually able to take an iPhone, jump into an application that's able to obtain 3D images that stitches them together and obtain using LiDAR highly accurate images of canine oral tumors. And right now, our pilot study is fully funded. We're detecting sort of its ability to and accuracy against the standard of care, which is CT measurements or something really rudimentary like physical measurements with a caliper. But the benefits of this is basically that we want to be able to take those photogrammetric 3D scans and start to apply deep learning to be able to evaluate and get textural analysis, volumetric analysis, and help with remote disease monitoring and remote clinical trial monitoring. And I do want to go back to one slide for 1 second. Hopefully this will load. I just want to show you sort of the detail that we're able to obtain here. And this is just a video representation of a scan that I took on a patient a few weeks ago. But within about sort of 10, 15 seconds, I was able to capture this scan. And you can actually see this large tumor over the dog's gum line here, which actually came back as a melanoma. But again, this technology seems to be really quite accurate, both from a LiDAR scan perspective, from a sub-millimeter precision, but we're acquiring data to be able to actually take platforms like Voxel and actually be able to do automatic tumor segmentation and volume correlation. And this is just another slide sort of highlighting that if we can correlate image features with textural analysis and then ultimately histologic features, we can start to apply that to things like radiation side effect likelihood, which has been done in the human space, responses to therapy, immune cell infiltration, which is important from an immunotherapy standpoint, and ultimately tumor type and predicting outcome as well. We're also looking at automating tumor segmentation models in canine oral tumors. And this is being done with work from our collaborators at Sick Kids, Andre Telfer, who we've recently been able to sort of grab a large image bank of dogs with oral tumors, one of the photos you see on the right there, and really try to capture an ability for automated tumor segmentation, which again will only help some of our other research projects in the future, but also do this for the first time in the veterinary space. And you heard from the Voxel team already about MedSam and MedSam2. Well, our goal here is to evaluate YOLO V2's ability to put a bounding box around an abnormal area, the SAM model to actually provide that segmentation versus a MedSam versus a MedSam2, but then also fine-tune development that into the veterinary side, which means that we're going to be doing this for the first time. Nobody else is doing this right now, and actually tuning a model that is very specific to canine patients, canine oral tumor patients. And right now, we're still in very early stages. We've been able to achieve an IOU of about 0.46, which obviously isn't the greatest, but we're at very, very early stages with our small data set. And we are implementing, again, looking at and hoping that a model like MedSam and MedSam2, which is trained on clinical human data, will hopefully perform a little bit better than the traditional SAM model. But if we can fine tune better, we may actually get a better approach. This is just some preliminary photos that I was sent last night from Andre, and I saw him here, so thank you for those. But this is just an example of what the SAM model is actually able to achieve within that bounding box, and really with quite high accuracy, at least based on these initial images. You can see that the tumor segmentation is really quite accurate. And again, the hope is that we can start to translate back to the 3D modeling that we already spoke about and start to get volumetric and textural assessment rather than having to manually contour all the time or do this in real time. We've also been fully funded by the American Kennel Club, Canine Health Foundation for extracting AI and CT features to predict sentinel lymph node metastasis in dogs with oral tumors. And so just to give you a little bit of background, sentinel lymph node mapping is done in the human space routinely. The classic example is breast cancer in women. The sentinel lymph node is defined as the first lymph node that a cancer may potentially spread to. And so the idea here is that you can actually inject a radioactive dye into or around the tumor bed, watch it drain to the specific lymph node using some form of imaging, and then that effectively becomes a lymph node that you want to remove alongside the tumor. And the idea is that in the human space, and definitely in the vet space, there's been a few clinical studies that if we can reduce the disease burden or effectively downstage the patient, we can actually provide a much longer survival than if we hadn't done that in the first place. The problem is that sentinel lymph node mapping is very burdensome, especially in the head and neck area, and can lead to a lot of inflammation, swelling, and a lot of post-operative complications. So our goal was to say, could we use CT image features, extract using pi radiomics the textural analyses from that CT, find candidate radiomic biomarkers, and then actually pre-predict lymph node status. And so we had a decent group of patients for the veterinary space, which turned out to be about 200 lymph nodes that were all segmented by my colleague, Dr. Ryan Appleby. He's a veterinary radiologist. And then my colleagues, Andrew Legree and Dr. Tran, went through and developed our sort of preliminary supervised classification model. And from there, we got these sort of preliminary results that really highlighted that, yes, we could predict this idea around lymph node status, but unfortunately, a very, very high level of overfitting, probably attributable to our small patient number. But I think, again, it sort of calls for this idea of we can run these preliminary assessments and be very happy with the fact that we've done this preliminarily, but there is opportunity not only for collaboration, but for a lot of generative modeling, a lot of generative AI in the veterinary space, because we are constantly, unfortunately, hindered by the fact that our patient numbers are usually much smaller than in the human space. And even though this isn't computer vision related, because we're talking about comparative computational oncology, I just wanted to briefly mention some of the work that we've already done as well, just as a little sneak peek. For those that are interested in language modeling, we have evaluated a named entity recognizer using a human named entity recognizer here from the University of Toronto and directly applied that to veterinary medical text from the oncology space and compared that against myself as sort of the gold standard, a veterinary intern, Dr. Andrew Poon, who's featured here, and then also looking at some cross-validation as well. The take home here from this study, and I apologize for all the numbers, but the take home from this study so far, and this has been submitted to Veterinary and Comparative Oncology this year, we're just waiting to hear back, was that at the end of the day, direct translation of human models to the veterinary space does not work very well, at least from a language perspective. And therefore, we really need people to be doing the groundwork in developing these models in veterinary care specifically to then either translate back or tune the models that are specific to the veterinary space as well. Dr. Wu was also very pivotal. We've got some preliminary data of looking at protein folding and looking at some standard, I know AlphaFold 3 is out now, but AlphaFold 2 at the time, evaluating its ability as well as ESM fold to actually fold canine proteins and looking at their sort of accuracy assessment. And what you can see on the right is that some of these models do perform quite well depending on the protein in comparison to the human metric. But there's still a lot of work to be done from the canine space. And we're actually looking at merging a lot of the technologies around these protein folding algorithms and calling it fusion fold for that reason, that could potentially fold canine proteins as well. So really, you've heard me talk a lot in kind of very superficially at sort of a 20,000-foot view about veterinary oncology and comparative oncology today. But some of the other details around comparative oncology is that you've heard that some of the responsibility about utilization of AI in clinical practice may fall on the clinician, which is the case in veterinary medicine as well. But access to data is somewhat better in the veterinary space because there's a lot of less regulatory hurdles. It's both a blessing and a curse because we're seeing a lot of platforms come out into the veterinary space now without that regulation that are simply, defining sort of what AI might mean in the veterinary space. But there's also a real opportunity here as a playground to test and deploy models that can really impact human health and veterinary health, obviously, as well. And it's also people like you that can use platforms like Voxel and join people like us to be able to help set standards, generate new ideas, and really improve lives of pets and people. And at Animal Health and specifically, we are also very passionate, as you saw with the iPhone study. We are really, really passionate about spatial computing as the next logical step. And there's this whole idea of being able to apply a lot of the machine learning algorithms that we're already working on into a spatial computational context. For those of you that are interested, I'm also guest editing this upcoming issue for BMC Veterinary Oncology, which is a relatively new journal, but part of the BMC family. If there's any evidence or interest in a publication, we are specifically looking for data science and AI-based frameworks and publications that are specific to the veterinary space and hopefully veterinary oncology space as well. So just a call for papers there. That's pretty much it right now, but please, I'm really excited to be here today, and thank you to Jimmy again for the invitation, and both Dr. Wu and I are happy to take any questions.
Fantastic, very illuminating thought or talk. We do have a few questions, so let's grab a few real quick. The first one is iPhone is using other sensors in addition to photos for 3D reconstruction. Is that true? If so, can you elaborate on that? So I'm assuming the question is about using other capabilities of the iPhone to capture additional data.
Yeah, so the company that we're working with, they've sort of rebranded, but Trinio was the application before. They're now Scanland is their new branding. But we contacted them, a couple of years ago because they actually developed during COVID the photogrammetry, which obviously, yes, is housed on board on the machine. You take effectively when you're taking a video around the patient, you're taking a bunch of photos and it's going to stitch those together to create the 3D meshwork, but you do need a machine learning algorithm that's going to stitch that together. And so they've got their proprietary models that they're working with us on to actually be able to execute in the veterinary space. So the main sensor is indeed the LiDAR scanning, but then it's taking all of the positional data, orientation data, as well as the photos themselves to stitch things together into a 3D meshwork. So I hope that answers your question.
So one other question, and this was more about your model selection. Someone noted that you were using the YOLO V2 model. Well, we know that there are derivatives of the YOLO model, but then there's also the YOLO V8 model. So I don't know if it was a question of the timing in which the research was done, but any commentary on why you were using an older version of YOLO versus some of the newer ones that have come out?
Yeah, so a lot of it had to do, at least right now, with really a notebook that we had pre-set up, or the collaborator I'm working with, Andre, had already pre-set up. But you're absolutely right. That's part of the reason too that we're sort of instituting things like the MedSam and MedSam2, is that we want to try and evaluate what's sort of up and coming. And, I obviously can't speak for him. I think I did see him in the list here in Quan. I don't know if you know otherwise, but I assume we'll be bringing the V8 model to the ground as well. But it was really for bounding box detection first and foremost.
And then we have one additional question here is, are there any studies which show merit of pre-training on human data?
It's a great question, and no. Really, our study, the NER paper that I mentioned, is the first one to translate a human model into the canine space. So obviously not computer vision, but that's the first time that they're doing that. I think, I've always had sort of this idea and passion as well. We know that there's a lot of issues in the human computer vision space around, racial detection, bias, the racial biases we bring to the clinic, et cetera. And there's a group from, I think it was MIT and U of T, that they could apply a bunch of filters to radiographs. And even when that image was completely black or completely white, their algorithm was still able to detect race. We have the benefit of, okay, we don't have race, we've got breeds of dogs, but can we actually use dogs as a fundamental way to start to parse through why that machine learning algorithm is able to do that?